Okay, there being no questions, we'll move on to tumor immunology topic. There has been a lot of investigation in the to study the role of immune system in the development and progression of tumors. As a matter of fact, those are the studies that very early 19th or 20th century studies, late 19th century and early 20th century studies that led to the discovery of MHC in animals first and then humans later on. In order for the immune system to react against, there's got to be something different, because otherwise the tumor is a self-tissue. There shouldn't be any reactivity to the cell tissue. What led to the belief that the immune system does have a role to play in tumor progression and its rejection, its regression and rejection, were a number of facts. Some came from the clinical observations, other from experimental models. And what I'll do is I'll go over what is the evidence for role of immune system in tumor immunosurveillance. Evidence for immune reactivity against tumors. Those humans who were unfortunate to have some sort of malignancy or the other, often they had antibodies that reacted with the tumor tissue, malignant tissue, but not with the normal. They also had lymphocytes that reacted to extracts of tumor tissue. We're going to talk about a little bit more about that, but also we'll talk about what are the changes that occur during the progression of normal to malignancy. We'll talk about tumor and host components that affect tumor progression. Okay, and then we'll talk about how the observations that there is immunogenicity of tumors used for the treatment and management of tumors. The evidence for role of immunosurveillance in malignancy is, first of all, there is an inflammatory response in the tumor. And early on it was observed, and if one looks at it, actually one can see mononuclear infiltrates in tumors, and one can find, if one can stain those, one can find T cells, both CD4 and CD8 T cells, mononuclear cells, and other inflammatory cells as well. This just represents that they are CD4 as well as CD8 cells. You don't see the different colors here, but this was taken from your book, and if you look at the book, there are clear differences, and they are both CD4 and CD8 cells found in the inflammatory tissue. There was also a relationship that, although that has become somewhat dubious as to how strong that relationship is, that there was a relationship between good prognosis and more infiltration. In other words, more inflammatory response and better prognosis with that tumor. Okay, here's actually CD8 cells, positive cells, and CD4 positive cells in the inflammatory in the inflammatory areas of around the tumor or within the tumor. Association with immunodeficiency. A lot of immunodeficiency diseases are those who have immunodeficiencies. They also have higher incidence of tumors, higher frequencies of tumors. Primary immunodeficiency. There's a lot of lymphomas that are associated with primary immunodeficiency. Cancer patients. There's a table in your book that shows a lot of correlation between different kinds of tumors and the transplant, the immunosuppressive treatment for transplants. So whenever there is immunodeficiencies, there are one or the other kind of malignancy. acquired, and one of the acquired examples is the immunosuppression for transplants. And there are higher incidence of lymphomas, cervical cancer, liver cancer, skin cancer, Kaposi's sarcoma in those patients. And another example, of course, HIV infection. It is associated with much higher incidence of Kaposi's sarcoma. Okay. In malaria patients, there is some immunosuppression induced by the malarial parasite, and those patients have got higher incidence of Burkitt's lymphoma, EB virus-induced Burkitt lymphoma. And then during autoimmune diseases where there is imbalance of immunoregulation, there is also some of these are also associated with lymphomas. So whenever there is a defect in the immune system, that can lead to higher incidence of malignancies. And that gives an indirect evidence that there is some role for immunodeficiency, for the immune system in regulating progression or onset of malignant diseases. Then the experimental evidence comes from the animal model, where one can immunize animals with tumors. I'll show you some animal models later on, how those experiments were done. Okay? Immunity is transferable from immune animals to naive animals. So you can immunize the animal. They will be resistant. Not only that they will be resistant, but you can take their lymphoid cell and transfer into naive animals, and these recipients will also become resistant to their tumor. Clinical significance of that is there because there are immune cells that are being stimulated in vitro and being transferred into patients with malignancies. That's the one form of immunotherapy. We'll talk about that later. Tumor-specific antibodies and cells have been detected in humans with some malignancies. Also, of course, it has been shown in animal models as well. I mentioned that earlier. Okay. Obviously, as I mentioned earlier, in order to have an immune response against a tissue that originated within the cell, there has got to be some difference between the normal and the malignant self-tissue. And there are a variety of tumors where new antigens have been characterized. Some of it fall in sort of what is referred to as oncofetal antigens. These are antigens that are expressed primarily in the fetal tissue during the tissue development, or on cells that are in the process of differentiation, and I'll give you some examples of those later on. Okay? The two examples that I will dwell on has got some clinical relevance are alpha-fetoprotein and carcinoembryonic antigen, and there is another one, CALA, C-A-L-L-A, chronic lymphocytic leukemia, I think it stands for, but I'm not, I won't bet on that. Okay. Oh, common acute lymphocytic leukemia antigen. It's also referred to as CD10. This is normally present on very early, undifferentiated pre-B cells. But in the case of malignancy, that antigen persists on these cells. So essentially those leukemic cells are undifferentiated cells that have been arrested at that pre-B cell stage. Okay? And the antigen is used for diagnostic purposes for characterizing the tumor, the leukemia. Yes. B cells. Undifferentiated B cells. CD10 is very early antigen on pre-B cells. Okay, so these antigens, let me emphasize again, are normal antigens, but not normal for fully differentiated tissues or adult tissues. Then there are tumor-associated transplantation antigens. These are characteristic of tumors. They are present on tumors, And since they are present on tumors, any immune response will lead to rejection of that tumor. And that's why they are also known as tumor-specific transplantation antigens or tumor-associated transplantation antigens. They're actually on cells, whereas the antigens like alpha-fetoprotein or CEA can be secreted antigens. Alpha-fetoprotein actually is almost always a secreted antigen. CEA can be found both on tissues as well as in secretions. And CD10 is primarily on the cell surface. Okay. Some of these may be virus-associated antigens. There are a number of viruses that cause human tumors. Kaposi sarcoma has been shown that the cause for that tumor is a herpes virus. When Dr. Richard Hunt starts his section, he will have a whole lecture on oncogenic viruses. Okay? Human papilloma virus. Human papilloma virus has been associated with cervical cancers. As a matter of fact, there is an attempt to have a vaccine against that. Okay? Then there are tumor-specific transplantation antigen as opposed to virus-associated, and these are on spontaneously occurring tumors where there's no virus etiology established. And best examples of that are really animal tumors, where one can, in a normal animal, inject certain chemicals and induce a tumor. So those are different types of tumor-associated or antigens that are seen during malignancies. I'll tell you a little bit about the clinical use of alpha-fetoproteins. It is particularly increased in testicular and liver cancers. And I've got one example of how it has been used in staging or diagnosis of testicular or liver cancers. Okay? It can also be used in patient management, how their treatment is going to be given. You'll see, it will be more clear when we actually come to the example. It is also used for sort of detection of tumor, meaning that you suspect that if levels of those antigens, those proteins go up, you suspect that there is some kind of malignancy, particularly of those. Here's an example of following a patient and testing for alpha-fetoprotein. There was a diagnosis of a tumor, of course. There was archaeectomy performed, removal of the testes. And prior to that, there was a fairly high level of alpha-fetoprotein. The normal levels are around, 20 nanograms per ml in the serum. So it's a low concentration present in the normal individuals as well. But during malignancies, it goes up. As you can see here, about fivefold that of normal level. And after archaeectomy, it came down to more like normal levels or below that. Okay? Upper limit of normal concentration is here. Okay, but as with time went on, this started increasing. And at this stage, there was a detection of a recurrence of the tumor, and the person was treated with chemotherapeutic agents, and with that, the levels went down again, okay, and remained low with maintenance therapy. So the bottom line is, take-home lesson is, one can use the concentration, blood serum concentration of alpha-fetoprotein to monitor a patient. And if it starts going up, one has to get worried and get concerned and investigate for the recurrence of tumor and apply treatment. Okay? The concentration normal is less than 20 nanograms per ml is abnormal concentrations. If they are abnormal, 100 to 350, possible malignancy, particularly of the liver. Okay, it's used in liver cancers. Okay, 350 to 500, probable hepatoma. Further up, 500 to 1,000, likely hepatoma, and 1,000, over 1,000, you can almost be certain that it is a malignancy of liver. Yeah. Testicular cancer is similarly. So you've got to investigate what it is, okay? Similar concentrations. You do not have to memorize those exact numbers, but know that, okay, from 20 to 100, 5-fold increase, or 20 to 1,000, that's 50-fold increase, should lead you to be concerned about the patient, who you are monitoring. Okay, CEA is a similar antigen, but not in this case, not liver cancers, but colon cancers is more characteristic of, although it has been seen increased in mammary tumors and some other tumors as well, but more broad range of tumors. It is once again used for staging and prognosis, monitoring response therapy, and detection of tumor recurrence. The example is here. Here's an example of colorectal cancer. Start off with here. There was there was a surgery for local recurrence. This is for after primary surgery or resection of tumor. It is fairly low. It started increasing, and it was determined that there was a local recurrence. It was removed, came down again, and as it started going up, there was chemotherapy administered, and it starts going down again. Again, there was a recurrence here, and that correlated with increased levels of CEA. That was removed, and it came down again. Okay, so CEA, just like alpha-fetoprotein, can be used to monitor, and any increase in its levels is indicative that there is either metastasis or local recurrence. Is a diagnostic adjunct, symptomatic, indicates symptomatic patient, elevated values of 5 to 10 times the upper limit are indicative of that. Yes, there are other conditions, okay, and I'll tell you, a little bit later on. Alpha-fetoprotein and CEA both actually have been shown to be in hepatitis of different kind. Alpha-fetoprotein in the case of hepatitis, CEA is increased in smokers, and heavier the smokers, the higher the levels. Okay, but never tenfold or to that, magnitude. Okay, in this case, normal values are obviously 10 nanograms per ml. So, you've got to pay attention to the history as well. Slight increase or twofold increase, you may further investigate that, okay, the person is a smoker or non-smoker. Okay? Or if it is alpha-fetoprotein, does the person have other conditions that may cause liver inflammation? Hepatitis. Okay. Transplantation antigens. Now we come to sort of experimental models, how it was shown. Has been a lot of work with animal models of tumor. Okay. And what has been seen that certain viruses can induce tumors in these animals. And this is an example of what are the characteristics of virus-associated antigens. Okay? Tumor-associated transplantation antigens, but virus common to, virus specific or virus induced tumors. One can inject with a virus, SV40 is one of the examples. One can get the tumors of different histological types or more than one tumor. If one takes out one of those tumors, okay, referred to as A and B, makes a cell suspension out of that, okay, from those tumors, immunizes an animal with a radiated tumor of the A type, okay, and then challenges 2 weeks later with either the same tumor, A tumor, or tumor B. If one challenges with tumor A, one gets a protection against tumor. Okay? Not only that, but also, although immunized with the tumor A, induced by that virus, a challenge with tumor B does not result in a tumor growth. So there's a cross-immunization with the two tumors induced by the same virus. And that is because the virus determines what tumor-specific tumor-associated transplantation antigen is induced in those malignant cells. It's the virus that determines it, and it's a common antigen. Okay, the bottom line, just to summarize it, if a tumor is induced by a virus, if more than one types of tumors are induced by a virus, all tumors induced by that virus will share the same tumor-associated antigens. Cross-protection. Okay, as opposed to that, if one induces a tumor with a chemical, and there are lots of chemicals that are carcinogenic, one of them is methylclanthrine, MCA, one can use, and that has been used to induce a lot of animal tumors. One injects the chemical a few weeks later, may take more than 2 weeks, may take a couple of months even sometimes. You may find one tumor or more than one tumor in these animals. One can assign them A and B and isolate those tumors, same way as the last experiment. One can immunize live animals